Thank you. Hopefully this mic works, and I also feel a bit self-conscious about the situation and the interesting introduction by Dr. Gill. I was also a little self-conscious, actually, when I was asked to give this talk because I hadn't really given this TED-style talk before, so I had to go online and actually search out, what are the characteristics of a TED talk that you need to consider. And while I was online, I got actually distracted by a very interesting website I found, which is a website that actually gives you a picture of a dilapidated house and asks you to guess, do you think this house is a crack house, or do you think it's a house that sold for over $1 million in Vancouver? Very hard to tell the difference, actually, between these two. This is a fine structure that sold for $1.3 million a few years ago, and I sort of, in error, guessed that it was a crack house. So I started thinking, what are some of the similarities between glomerular disease and Vancouver real estate market? And actually, there are quite a lot of similarities between these two processes. So in terms of interest, I think Vancouverites are relatively obsessed with their local real estate market. Every couple of months, there's a headline on the front of the newspaper about how prices are soaring. And as we all know, home ownership in Canada is at an all-time high. There's also, I think, a huge interest in glomerular disease. Fundamentally, these are a group of diseases that pathophysiologically are quite interesting. They're autoimmune. They target younger patients. They're relatively rare. And most importantly, they are treatable. So as opposed to a lot of other forms of kidney disease where it's a long-term management approach, there are treatments for these diseases. However, there's also a lot of risk. So if you're going to buy a house in Vancouver, you're going to borrow a lot of money, and it's going to be the single largest purchase that you probably make. And in glomerular disease, there's a large risk of progression to end-stage renal disease if you don't treat it. But even if you do treat it, there's a lot of risk associated with the treatments. There's also a substantial cost. So I don't know how many of you read recently the median household income in Vancouver, the median household cost in Vancouver just hit $1.47 million. And this is compared to a median household income of $69,000. And the tragic ratio of these two makes Vancouver one of the least affordable cities in the world. And we also have some interesting problems with drug costs in glomerular disease. The immunosuppressant medications used to treat the diseases can be quite expensive over the long term. And we're also dealing with issues of inflated prices. So people have speculated in Vancouver, are there foreign ownership? Is there speculative buyers driving up the prices? And we also have, we're very proud in glomerular disease to say that we have the world's single most expensive medication. And I'm not sure how many of you saw the CBC documentary recently on eculizumab, but I don't know where they got their data from. But they reported that a single vial of eculizumab sells for $6,700. The cost to make it is $60. So, I'll leave it there. But the biggest similarity between these two is the lack of systematic data collection that prevents really studying these problems in sufficient detail. And this is the similarity I'm going to focus on for the majority of this talk. And when you don't have good quality data, you're sort of prone to just continuing with the same messaging that you've been doing forever. And that messaging might be very biased. And an example here is Bob Marini. I'm going to pick on Bob Marini a couple of times in this talk, actually. He's a very large developer in Vancouver, who is quoted as saying, Vancouverites should really just give up on the concept of single-family detached housing, and they should embrace what he called housing density. Now, that's really synonymous with building more condos, which is very convenient because he's the guy building the condos and making all the money. So this might be one reason why real estate is now the single largest contributor to GDP in the province. In glomerular disease, we've taken a different approach, though. We said, the status quo wasn't acceptable. And in 2013, we created the GN committee through the BC Renal Agency. The overarching mandate of this committee was to ensure high-quality GN-related health services are available to patients throughout BC, so in a distributive model. The committee comprises of various different stakeholders. We have nephrologists on the committee from various different health authorities, including pediatric and adult nephrologists. We have pharmacists. We have Promise IT and statistical support, largely because there is a very strong emphasis on data collection, as well as renal pathologists. And the committee oversees a larger initiative called the GN Network, which really comprises the committee itself, as well as various focused working groups that target specific projects, and the GN Registry, which I'll talk about in some detail, which is a method of data collection for these rare diseases. So what are the specific goals of the GN Network? Well, it's really to create a sustainable framework for knowledge translation and policy development through the systematic collection and analysis of data. And we want to be able to implement and evaluate clinical care programs and health policy GN in a context that's financially stable. So there is an emphasis on making sure that there's a long-term financial sustainability to this process. We would like to promote clinical outcomes, health policy and health services research in glomerular disease at the provincial level. And importantly, we would like to ensure knowledge translation of these findings to key stakeholders in the province in this area. So what is the vision here? I mean, fundamentally, we would like to establish and coordinate the delivery of GN health services in a way that's totally analogous to other types of kidney disease. We already have good infrastructure for CKD, for ESRD, for transplant, but this was a group of diseases that was affecting younger patients. It was expensive to treat, they were rare, and there's a high risk of progression to end-stage renal disease, and there was simply not a very well-established infrastructure to treat them. There was an emphasis here on capturing the necessary data to systematically develop and evaluate our health services initiatives. We wanted to be accountable for the decisions that we make, and we wanted to be able to do it in real time. And we would like to be able to integrate health administration and research activities to create a framework for studying these diseases in a sustainable way across the entire province. Because when you're dealing with rare diseases like this, if you want to study it, you really do need to do it at the provincial level. So this is an example of what you can do when you have high-quality data. So this is a study done by a local mathematician in Vancouver. He linked the 2011 National Household Survey with data from the Canadian Revenue Agency. And what he did is he looked at people in Vancouver and looked at how much they spend on their annual household expenses. This would be things like your mortgage or your property taxes. And he compared that to how much income they declared to CRA. And he looked at the percentage of households in each census block in Vancouver that declare less money to CRA than is required to maintain their annual household expenses. And what he found is that when you go from east to west in Vancouver, so you go more and more and more towards those expensive neighborhoods, a higher percentage of households are declaring less money than is required to actually maintain their household expenses. And I've highlighted here the Arbutus Ridge and Dunbar areas, as well as the Shaughnessy areas, which have 20 to 40% households that declare less money to CRA than is required to maintain their household expenses. Now you might say maybe that's because they're really old and they're retired, they don't have any income. Well, when in fact you looked at the age, the median age of this group was less than 55. So this is the example of what you can do when you have high quality data. You can address a hypothesis in a systematic way. And I'll leave it to you to interpret the results of this particular study. But you don't have to go very far in the BC renal community to appreciate the benefits of data collection. JAG, for instance, is in charge of data at BCT. And if you ask JAG, what do you know about patients on the wait list? How many patients are there? How many of them are active? How many of them are on hold? Are patients dying on the wait list? How many transplants do we do every year? And if you get a transplant, what's the chances that your graft is going to survive X number of years? Well, JAG has the data to tell you all of those things. So he can tell you what's going on with patients who undergo a kidney transplant at all stages of their progression through the health services process. In GN, we didn't have any of this. So we created the GN Registry. And the goal of the registry here was to ensure that we had high-quality data that is available to develop and evaluate clinical care and health policy initiatives for the management of GN, and that would be done by the GN network. So this was a set of data collection that is embedded within PROMIS to really support the activities of the GN network. And as of now, we do capture information on all patients prospectively as of the time of their kidney biopsy. So this is a list of histologic diagnoses that makes a patient eligible to enter the GN registry. We were at the dinner last night for Alex McGill, and he was commenting that the histologic diagnoses change over time, so this will probably evolve over time. But this is how we collect the data. So what happens first in the left-hand column here is if you refer a patient for a kidney biopsy, a couple of things happen. Number one, they get registered in PROMIS automatically. And the patient gets identified as having a glomerular disease from the results of their kidney biopsy. So for those of you that don't know, all types of GN have to be diagnosed on a kidney biopsy. You really can't diagnose it any other way. So right now, when we do that, we're capturing patients with glomerular disease. They get flagged in PROMIS as being in the GN registry. We enter their histology data from the kidney biopsy into a database in PROMIS that we have now newly created. We capture some basic clinical data on the patients. PROMIS automatically links to get their lab data, their ESRD outcome data, and now through the GN formulary, which I'll talk about as well, we now get the information on their immunosuppressive medications. So how does this actually happen? Well, we have a data analyst in the background that manually enters some of this information. They manually register the patient in PROMIS and manually flag them for being in the GN registry. If you happen to be seeing your patient in a CKD clinic already, the variables we're interested in are blood pressure, height, weight, comorbidities, medications, and race, and these are variables that are already captured under the normal processes of care in the CKD clinics. You don't have to do anything extra. Some of you that have seen your patients in private offices have gotten the reminder fax in which we're asking you to send us your dictation, and we manually extract these key pieces of information for entering into PROMIS. So what can I tell you about the GN Registry? Well, keep in mind, this is a group of rare diseases, and it's been ongoing now for 2.5 years, and we just did our last data quality report at the beginning of this week, and we have 704 patients now captured in PROMIS with GN that would otherwise not have been captured at all. This works out to about 282 patients per year. And I think if you look at the distribution of diseases, it's pretty much as you would expect. These are all different kinds of GN. And posse-immune GN, or ANCA vasculitis, is one of the more common types in British Columbia, as is IgA nephropathy and lupus nephritis. There are several ultra-rare conditions, which I've listed at the bottom, C3 glomerulopathy, and another one with a long name I won't go through, but we do have these conditions as well popping up in British Columbia, even though they're ultra rare. Well, what can I tell you about the data capture that we are able to achieve through this mechanism? As you'd probably expect, the lab data is captured automatically, so we're getting it in about 90% of patients, very close to the time of their kidney biopsy. Some of the issues around race and blood pressure we're also capturing pretty well. As you go down this list, though, things like height, weight, we're not getting as often as we would like. Now, we are doing data reports, and we've done 2 of them now. And every time we do a data report, we take a look and see what kind of patients are we missing, why are we not getting the information, and we try to augment our logistics. And actually, the data capture rate is improving over time, so it is going up. So I think that over time, we will achieve more comprehensive data capture for some of the key variables that we're interested in. So this is the characteristics of some of the types of patients that are in the GN Registry. And I'm going to point some of these out for some of the nephrologists in the room that might be seeing this information for the first time. So I've categorized patients across the top as FSGS, which we don't know whether it's primary or secondary. FSGS, we think, is clearly primary from the biopsy report. ANCA vasculitis or posse-immune GN, membranous IgA, and lupus. And I think there's some key patterns that you can appreciate here. So under the FSGS group, you can see that these patients largely have decreased kidney function, and they have protein in the urine that is in the subnephrotic range, which is quite characteristic of secondary FSGS. The patients that have idiopathic FSGS, or at least that seem to have idiopathic disease from their biopsy, are often presenting with more normal renal function, but they're quite nephrotic. So their protein, half of them have proteinuria over 4 grams per day. If you look at the ANCA patients, these patients are presenting in British Columbia with very, very severe disease. So their creatinine at the time of biopsy is 232 on average. 25% of them have GFRs less than 12 at the time of biopsy. If you look at membranous nephropathy, certainly many of these patients do have huge amounts of protein in the urine and are quite sick, but half of them have protein in the urine that is in the subnephrotic range, which, so subnephrotic membranous is a big issue in British Columbia. IgA nephropathy is actually quite interesting. So if you take a look, about 70% of the patients, almost 60 to 70% of the patients have proteinuria over 1 gram per day. So if you look at the guidelines for treating IgA nephropathy, based on that proteinuria, that person might be eligible for immunosuppressive treatment. However, if you look at the GFR, it's 38. The average GFR is 38 at the time of biopsy. So we're biopsying these patients quite late in their disease course, and they might not be eligible for immune therapy because of the late presentation or the late biopsy timing for their disease. So this is quite interesting. This is the first time I can actually present anything in the way of outcome data for GN patients in British Columbia. And it's a little bit sobering, actually. If you look at the risk of end-stage renal disease, the 2-year risk of progressing to ESRD is roughly 15%. So it's pretty high. Now, obviously, the numbers in each subgroup here are not super high, but if you look at the risk by different disease type, I think to some degree it's what you would expect. The ANCA patients have a very aggressive disease, high risk of progression, and that's exactly what you see, especially within the first few months, that there's a high risk of progression to dialysis dependence. However, take a look at the IgA nephropathy group. So that 2-year risk of progressing to ESRD is around 20%. That's substantially higher than what you would expect from the existing literature, and I think it's consistent with the fact that we're really biopsying our IgA patients quite late in their disease course. What about mortality? So survival in this disease is not well described in the literature. We tend to focus on renal progression, response to immunosuppression, but we don't necessarily describe survival all that well. And again, it's a little bit sobering. So this is a group of patients that are very young on average. They don't have a lot of other comorbidities. And despite that, the 2-year mortality rate is around 7%. So that's quite high. I think it's as you would expect. The vasculitis patients, it's a very aggressive disease, do have a lower survival. But if you take a look at the secondary FSGS patients, they also have a significant mortality risk over a couple of years. And I think that's probably due to the comorbidities that cause the secondary scarring. So the hypertension, the diabetes that these patients tend to have. So what about costs? So coming back to the analogy of Vancouver real estate, the blue line here is the cost of a detached house in Vancouver from 1977 all the way up to 2014. And I've taken the liberty of circling some key time points in my life here. So the first circle is when I started medical school. The second circle is when I started residency. The third circle is when I finished residency. The last circle is when I got my first job. So you can see that I could not really have picked a worse time to do a prolonged 15-year period of medical training. If instead I was like, Jag or little people older than him, I'd done training the 15 years before, housing prices would not have gone up at all. So what about costs in glomerular disease? Well, what we did is we linked the pathology data at St. Paul's Hospital with PharmaNet data for the 13-year period from 2000 to 2013, and we looked at mostly immunosuppressive medications, not including rituximab. Rituximab was not used very often during this time frame, and we can see the costs are increasing quite significantly. Now, this curve is a little bit deceptive for theatrical purposes because the patients are being, more and more patients are being included in the cohort, but right at the end of the curve, even when you reach cohort saturation, costs are still increasing, and we estimated that the cost to treat glomerular disease in the province was around $2.5 million, and this is for a group of diseases that's relatively rare. So where did this cost come from? Well, it was actually quite surprising. So tacrolimus was costing around $1.2 million a year to treat these patients. And Cellcept, which the brand name version of mycophenolate, was costing around $800,000 a year. So these were the two largest contributors of costs to managing this particular group of disease. And we know that cost is a barrier to managing glomerular disease. Canada has actually one of the worst rates of access to medicines among comparable countries. So if you look at other countries that have universal healthcare systems, we do quite a bit poorly compared to them. So 1 in 10 Canadians cannot afford the medicine that their doctors prescribe, and that increases to over 25% if you look at Canadians that do not have extended healthcare insurance. And this problem is probably amplified in patients that are dealing with expensive treatments for rare diseases like glomerular disease. And we actually did a survey of nephrologists in British Columbia to ask them. And it turns out that 86% of nephrologists reported having very poor access to insurance coverage for immunosuppressive medications. And 98%, so almost all of them, considered a central funding mechanism for immunosuppressive medications as potentially improving patient care. So based on these results, in April of 2014, we started the GN Drug Formulary, which was essentially we took all the immunosuppressive medications used to treat these diseases and we added them to the BCPRA formulary. And the concept here is that there would be no user fees for patients. There would be either instantaneous or rapid approval in a way that is targeted and relevant to patients with glomerular disease. And the concept was to ensure equitable, evidence-based use of potentially life or organ-saving medications. And it seemed quite reasonable. It seemed quite unfair that if a patient had a transplant, they could access the same medications without a problem through BC transplant. But if they had a native kidney, they had quite a bit harder time accessing these same medications. So we projected what could be our cost savings if we did this. And there's several different ways we could reduce costs. We could use leverage the provincial HSS-BC pricing mechanism, and we could convert some of the brand name to generic immunosuppressive medications. And in our first estimation, we estimated that we could reduce the costs from about $2.5 million down to $1.5 million a year. How would we do that? Well, one example here was the conversion of Cellcept to generic mycophenolate. Many of the transplant programs worldwide had already done this, and the cost savings were substantial. We could reduce costs from $800,000 roughly down to about $150,000. This is a new initiative we've rolled out recently, so this is not included in the previous estimates, but we recently, on a provincial scale, converted from the Astellas Prograf tacrolimus to Sandoz tacrolimus. Same drug, exact same drug, but converting from a brand name to a generic. And tacrolimus was a big problem. As I mentioned before, it was costing about $1.2 million a year, and we could drive that cost down to under $200,000 a year. So this is a big cost savings for this group. And I think the concept here is that we are improving access, and we are reducing costs. But what about being accountable? We're making health policy changes. How accountable are we for those policy changes that we make? And an example is the tacrolimus conversion project. So after systematically changing the funding from brand name to generic tacrolimus, we are following all of these patients and evaluating their drug dosing, the safety and efficacy of transitioning from one drug to the next. And this would not be possible without the systematic data collection at the provincial level through PROMIS. And this is really the first opportunity in the literature to describe conversion at a large scale from brand name to generic tacrolimus and glomerular disease. It's certainly been done before in transplant, but has never been described before in glomerular disease. And so I hope that we can be accountable for the health policy decisions that we're making. Well, the goal is not just to reduce costs. The goal is also to try and reduce variability, and with the ultimate goal of improving patient outcomes. So we've also come up with various different treatment protocols and pre-printed orders, and these are available on the BCPRA website. Examples include the infusion protocols for cyclophosphamide and for rituximab, which have been approved in most of the health authorities so that you can infuse these medications through your medical short stay. There's a protocol for the treatment of IgA nephropathy with steroids, and we will be publishing soon the protocol for treatment of membranous nephropathy with calcineurin inhibitors or cyclophosphamide. And this is an example of the infusion protocol for cyclophosphamide. To give you an idea, previously, at least at VGH, we had to use a protocol more designed for cancer treatment, so it wasn't as relevant. At the beginning of the protocol is the standard information on pre-medications, intravenous fluids, but we've included default dosing and frequency specific to glomerular disease to make it easier for you to use this medication to treat glomerular disease. Examples include the NIH protocol, the UVAS protocol, the Eurolupus protocol. So instead of having to remember it or going back and looking it up, you can just tick a box and hopefully standardize treatment with this potentially very, very toxic medication. So what can I tell you about the actual costs of this particular program? So in the first fiscal year, we spent about $600,000. Now, keep in mind, we have not actually probably converted all prevalent GN patients onto the program, so these costs will go up as more patients move on to the program, and that's okay. We have spent about $350,000 on oral medications and about $250,000 for rituximab. And I just want to comment on that for 1 second. So rituximab is an expensive medication. It's adjudicated by a group of pharmacists through the Pharmacy and Formulary Committee. So each case is reviewed. And so we have now provided rituximab to 21 patients in British Columbia who I venture to say probably would not have got that drug under the previous system. So hopefully that's 21 patients that had a very good indication for that medication that have now gotten that medication and hopefully are doing better as a result of this particular GN formulary. So, when you don't have very good data and you don't have very good evidence, you're sort of prone to coming up with whatever solution comes to mind. And again, I'm going to pick on Bob Marini. So he was quoted recently as saying a speculation tax is what we need in Vancouver to address our housing affordability issue, with no data whatsoever to back that up. Other people have suggested, well, you know what we should do? We should just build really small houses in really unusual locations, and that'll solve our housing density problem. And I think that everyone can look at this picture and realize that's not really a very sustainable solution. In glomerular disease, though, we've taken a different approach. So we've focused quite extensively on integrating our health administration and research activities to create a framework to study these rare diseases. And the goal here was to make sure that it was sustainable and that it was distributed across a large population. So again, this is a group of rare diseases. If you want to study it properly, you're going to have to do it across a very large source population, which ideally would be at the provincial level. And I think this does improve patient care. It gives patients access to novel therapies that they would not otherwise have access to. And it allows patients to contribute to knowledge generation in their disease area so that they can help the next patient that comes along that has that particular disease. So how have we done in BC so far? So in the last couple of years since starting this network, we've been involved in 3 larger studies, one of which was the MENTOR trial. It recruited 126 patients from across North America. I'll talk about it in more detail, but the point I want to make here is that we recruited 12 patients in British Columbia, which doesn't sound like a lot, but trust me, that's a very large contribution to that particular study. And the key point is we're recruiting them across all different health authorities. So all nephrologists, all the nurses are out there identifying patients to recruit into this study across the variety of health authorities in this province, which makes this very much a provincial initiative. We were also looking, we're doing a translational study in IgA nephropathy in which we were looking at the relationship of disease activity to the enteric microbiome. And again, we were recruiting patients across a multitude of different health authorities. The last study is a phase 2 study. It's a little more involved for patients, so realistically, we were only able to recruit patients in a close geographic region to Vancouver. But coming back to the Mentor study, so this was a randomized trial that compared rituximab to cyclosporin for membranous nephropathy. And this study actually completed enrollment in the beginning of September, so enrollment is now closed. And these diseases, as you can imagine, GN has been plagued with problems of patient recruitment in clinical trials. This study recruited from the beginning to the end in about 2 years and met its goal target recruitment across North America. So this is actually a prime example of how good clinical trials can be done if you're able to recruit patients across large source populations. And the Mayo Clinic in Toronto were the 2 main sites. They started about a year ahead of us, so they recruited the most number of patients. But British Columbia contributed in a very substantial way to this study. So we're up there with Columbia University, and we're better than basically any other site involved. So I think we should be very, very proud of our contribution to this study. And I think this study will materially change the way we treat membranous nephropathy, and British Columbia will have contributed valuable information to this finding. We do have several upcoming trials in glomerular disease, and I'm going to highlight one of them now that I have a fixed audience. This is the testing trial in IgA nephropathy. It's a multi-center, international phase 3 study. In Canada, it's funded by CIHR. It's coordinated worldwide through the George Institute in Australia. We're going to be recruiting 1,300 patients from countries across the world. And we're randomizing these patients with IgA nephropathy to 6 months of steroids versus placebo. And we're following them for the long-term risk of a hard renal outcome. Now, the goal of this study is to try and address the controversy that has plagued this area before. I think our biopsy data would suggest that physicians have equipoise around whether they should treat patients because they're biopsying them late. There's a lot of controversy in this area. Are steroids effective or not in IgA nephropathy? And this study is going to be, hopefully, the study that solves this controversy for us so that we can move on in the treatment of IgA nephropathy. Now, we'll be sending out more information by email. Recruitment will probably start sometime in November. But again, the goal here is to recruit patients using the infrastructure we have available across the larger provincial community. So I think, in conclusion, housing affordability is really at an all-time low. There is no short-term solution. And in case some of you might not have guessed, I might be a little bit bitter about that. However, I think in British Columbia, we've made improvements in glomerular disease. Our provincial health services delivery, data infrastructure, and research in GN are now substantially better developed. And I think we are improving patient care and improving patient access to medications that are helping treat their diseases. I would point out, though, that there's probably a lot of room to still improve. We want to achieve a similar infrastructure that's already been developed for CKD, for transplant, for ESRD, and we'll be working over the next few years to try and achieve that goal. So I'd like to take this opportunity to thank specifically the members of the GN committee that have worked hard on the individual projects. I'd also like to thank Clifford Lowe. So I don't know if he's here today, but Cliff worked very, very hard on the GN formulary. And I don't know how many of you know this, but he actually won the BC Patient Quality Safety Council Award in 2015 for this particular initiative. So I think we all owe a lot to Cliff's work on this particular project. I'd like to thank Gabriella, who has done all the statistical analysis for our GN projects. James for developing the data reports, which were not previously developed. And as I mentioned, the GN Registry has data analysts working in the background. Those people are Tanya Chung and Anna Johnson that have worked very, very hard to help us out with the data collection. I'd like to specifically thank Alex McGill and the St. Paul's Pathology Department because they've been very, very, very supportive of integrating the logistics of biopsy specimen processing with our logistics of data capture so that we can capture patients as of the time of kidney biopsy. We have a research team working behind the scenes to help support the provincial nature of these research projects. And most importantly, I'd like to thank every single nephrologist in the province, because we've all been very, very supportive of this particular initiative, supportive of enrolling your patients in the GN Registry, and very supportive of enrolling your patients in clinical trials. So thank you very much.
I'm feeling riddled with guilt. First, I felt bad about wearing a suit. Now I feel bad about owning a home. So if we do have time for, we're running a bit behind, but we have time for a couple quick questions if people have any. In the meantime, maybe I'll ask Sean kind of a quick question. So it's laudable what you've accomplished, and I think there's a lot of lessons to be learned in terms of the setup of something. And I think there's definitely an appreciation now that within the buckets of CKD, dialysis, and transplant, there's important subgroups of patients that we need to look at more carefully. Just yesterday at our nephrologist meeting, we were discussing polycystic kidney disease and genetic diseases that need to be followed in a registry format. What are some lessons that you would offer, or things that you think in terms of the logistics of setting that up, particularly in terms of the data capture piece, that you think you could have done differently, or you think you're going to mold differently moving forward?
Yeah, I mean, I've gone through a lot of overview, and I think the largest challenge here is the specific details of how these patients move through the healthcare system. And you can't look at that at a high level. You have to go down and actually look at that at a detailed level of all the way down to, if you order a kidney biopsy, where does that specimen go? How does that accession list get processed through the St. Paul's lab? And if you don't do it yourself, you're really not going to know. And that was actually one of the key mechanisms of us capturing these patients, was understanding how we can get the information about the patients to register them in PROMIS at the time of the kidney biopsy. And that's one example of having to really go down into the trenches and examine the data collection mechanisms quite carefully, so that you know where you can insert your planned data collection and how you want to change it over time, and understanding what are the key variables that you need. I mean, there's the variable set that's obviously nice to have, but there's the one that's obviously the smaller need to have. And how are you getting those? And how can you augment it in a way that is automatic and sustainable? Because if you go out there and you say, well, I'll just ask everybody to enter this information, that's not going to work. People aren't going to remember. They don't have time in clinic to do it. And you have to find ways to automate the process. And so if you want sort of wide versus deep data, you kind of have to make a sacrifice in that regard. So it's really, I think, looking at the details of how you want to collect the data, automating the process, and minimizing it down to a minimum data set that you think is important.
Thanks, Sean. Any other questions at all? If not, I'd like to thank Sean for a great presentation. Thank you. Oh, sorry. There is one question.
Really quick question for Sean. When the biopsy's done, who puts the information into PROMIS, and where is it the best place to be captured for your data?
Yeah, thanks. So one of the issues was a lot of data was already collected in PROMIS. In fact, all this data was already collected in PROMIS. But if it's collected in a PDF format, as a scanned document, it's not really analyzable, which makes it quite challenging. So, for instance, pathology reports were already captured in PROMIS. That wasn't an issue. There was already an automatic linkage with COPATH. The issue was, how do we extract that information and put it in a way that you can analyze it? So that's where the data analysts, Tanya and Anna, come in terms of helping us manually enter that information into the pathology database that we've now created in PROMIS. I mean, it's very, very, very unique. PROMIS is a kidney disease database, but there was nowhere to actually enter a good quality kidney diagnosis. So we created it within the pathology database so that we can enter detailed pathology diagnosis and renal biopsy information, which we're just extracting from the PDF files that were already there. It's just that when they're in PDF format, you can't analyze it in any way. So, thank you.
Thank you. Janice.